Support for this podcast comes from Bryn Mawr Communications. BMC produces a number of informative podcast series spanning a variety of topics in ophthalmology. Discover a new show at itube.net/podcasts.
Hi, we're back with yet another episode of the Mod Pod, and this month we're going to share a few more articles from our July-August issue. Hope you're ready, because we're going to dive right in. If you treat patients with dry eye disease, perhaps you've had some trouble with reimbursements for in-office MGD procedures. Whether that's the case or not, Myranda Partin of Oklahoma Eye Surgeons in Oklahoma City, Oklahoma, has a few tips for some of the most commonly used therapies.
Dry eye disease is primarily characterized by a dysfunction of the tear film, which is divided into three layers: lipid, aqueous, and mucin. Composing the lipid layer are the meibomian glands, and meibomian gland dysfunction is the main contributor to dry eye disease, given the meibomian gland's role in tear film homeostasis. Behind the slit lamp, MGD can be seen in the form of saponification, or foamy frothy tears, or upon direct expression of the meibomian glands. Healthy glands should secrete a clear meibum, with various forms of viscosity can be seen in cases of MGD depending upon the severity. Obtaining insurance coverage, though, for therapies to treat MGD with any medical insurance company can be challenging, and oftentimes patients are left with the only cash pay option. I'll review some of the available tools for treating dry eye disease and the cost to patients for their use and relative CPT codes associated. Slit lamp anterior segment photography is a great patient educational tool. The CPT code 92285, external ocular photography with interpretation, can be used for this service. The 2018 Medicare physician fee scheduling allowable is $21.24. For tear film imaging, CPT instructs providers to use the code 0330T, while 0507T is the appropriate code for near-infrared light meibography. Although there are no limitations for repeat imaging, valid documentation is required with the reason for additional images. Our office will typically assign an Advance Beneficiary Notice, or ABN, to images and procedures because reimbursements from third-party carriers are unreliable. The BlephX is a quick and easy procedure performed in office that uses mechanical debridement to remove debris and bacterial biofilm around the eyelids. Although BlephX does not have its own CPT code, the code 92499, which is used for ophthalmological procedures that don't have a specific code. BlephX is relatively inexpensive for patients. It typically costs between $150 and $250 per treatment and is recommended every 4 to 6 months. BlephX is well tolerated amongst all ages and skin types. The LipiFlow includes bilateral thermal pulsation therapy with coinciding lid massage that usually lasts about 12 minutes. Treatment is repeated yearly and costs between $750 and $1,500 per session. Category 3 or T codes like 0207T and 0563T were used for thermal lid treatments such as the LipiFlow and TearCare systems, but the National Government Service recently removed the use of these codes for both procedures. The TearCare provides localized thermal therapy using proprietary smart lid technology in which multiple temperature sensors communicate with the companion smart hub 240 times per second to ensure heat is closely controlled and consistent throughout the procedure, which takes about 15 minutes and requires manual expression of the meibomian glands afterwards. It is recommended about every 6 months and typically will cost your patient between $500 and $700. The Sustain iLux is another thermal therapy option that uses an LED heat source to warm the lids between 100 and 108 degrees and turns off once the target lid temperature is reached. Most optometry offices charge patients around the same as tear care for this thermal procedure. The root cause of dry eye disease is cyclical inflammation. With intense pulse light therapy, the light from the laser is selectively absorbed by telangiectatic blood vessels, causing them to shrink. This effect decreases the inflammatory load and number of cytokines around the eye. IPL can also rid the lids of Demodex, which infiltrate the meibomian glands and cause dysfunction. Most IPL therapies cost around $400 per treatment and require at least 3 treatment sessions to experience results. The OptiLight does not have its own CPT code, but many offices will use the 17999, which is for unlisted procedures for skin, mucous membrane, and subcutaneous tissue. iLight combines IPL and low-level light therapy to enhance cellular processes through mitochondrial cytochrome C oxidase modulation. No gel is required, and LLT is considered to have favorable safety factor on application to the upper lids. The CPT code 17999 can also be used for this IPL treatment. Equinox low-level light therapy is another option. This treatment takes around 15 minutes and uses photobiomodulation technology that stimulates the production of adenose triphosphate. Intraductal meibomian probing with the Maskin-2 is not associated with a specific code, but the 67999 would be an appropriate non-reimbursement medical code to use with this procedure. Probing activates stem cells, which initiates proliferation and debrides the ductal epithelium, leading to a better outflow with growth of meibomian glands. The MIBA ThermoFlow device features a reusable probe that delivers thermoelectric heat for 8 to 12 minutes during each of the 3 treatments, spaced about 2 weeks apart. Each treatment session with MIBA ThermoFlow will cost your patient between $100 and $400. Patients around the world experience the symptoms of MGD, and we have an increasing number of tools available to us which offer them relief. However, providers do not seem to be pushing insurance companies for coverage because reimbursements aren't always enough to cover the cost of devices themselves. Remind your patients that they can also use their flex spending accounts to cover treatment and consider offering payment plans to help cover the necessary procedures. Diagnosing MGD early is key to preventing patients with even needing treatments with aggressive therapies. Do everyone a favor and be sure to educate your patients on proper lid hygiene, blink rates, screen time, and the use of dietary supplements, which can also have a significant long-term outcome.
What did you think? Was Dr. Partin's article useful to you as a practitioner? Let us know. Email us at editors@bmctoday.com. Before we move on to our next article, we're going to dive into an early break, but it's a quick one.
Support for this podcast comes from Bryn Mawr Communications. BMC produces a number of informative podcast series spanning a variety of topics in ophthalmology. Discover a new show at itube.net/podcasts.
Okay, now let's hear Christopher Cook, Medical Director at Medical Optometry America in Newtown Square, Pennsylvania, share his 5 rules of thumb for managing the ocular surface.
With new options in dry eye diagnostics and treatment modalities continually coming out, practicality is king in the hectic world of today's optometrist. Fine-tuning your approach to managing dry eye is essential for the streamlined care of this onerous disease. Following the simple rules of thumb outlined below can help you improve the way you handle the many presentations of dry eye disease. Rule number 1, focus on patient history. It has been said that with only a well-collected patient history and initial workup, a correct diagnosis of dry eye can be reached 80% of the time. Dry eye questionnaires such as the Standard Patient Evaluation of Eye Dryness Questionnaire, or SPEED score, or Ocular Surface Disease Index, or OSDI questionnaire, should be common practice at this point. They take no time away from your schedule and provide a volume of information before you ever turn on the slit lamp. If you're comfortable letting a questionnaire guide your technicians, develop a cutoff range that allows them to suggest point-of-care testing, such as tear osmolarity, MMP9, or tear quantity based on the survey outcome. Again, before you have even set foot in the exam lane, the patient's history should have guided analysis to give you pertinent information on tear quantity or quality. Patients rely on their doctors to be effective communicators, and they occasionally relay to us things they don't divulge to technical help. By briefly reviewing your patient's symptoms at your initial point of contact, you will many times uncover hidden gems of information. The types of symptoms associated with dry eye are well known, but the surrounding details can paint a different picture. Acute onset versus chronicity of symptoms is a good area to probe, as this will often guide treatment. If a patient has never had dry eyes until 2 weeks ago, it may steer your approach to initial therapy or lead to a different diagnosis. Medications and daily environment should not be missed when reviewing history. Antihistamines, anti-anxiety, antidepressants, and diuretics are all examples of medications that are known to negatively affect the ocular surface. Air quality and other attributes such as humidity are known to affect the eyes and can be amenable, so don't forget to ask patients about environments to which they live and work. Now that you've clarified your patient's symptoms and reviewed their complaints and history, it's time to focus on the examination. Rule number 2, use repeatable metrics. You may not have every type of point-of-care testing or instrumentation that provides tear film analysis, but even without these decisive tools, the clinical exam will guide your diagnosis and help you arrive at the correct therapy. Vital dyes can be placed first. Whichever dye you choose, though, be sure to allow enough time for that dye to equilibrate. You won't see tears breaking up on the surface of the cornea if you look immediately following installation. And it takes time for the stain to incorporate into devitalized or damaged epithelium. So try to form a habit of letting the dye do its job for about 2 minutes. Because there are many surface grading scales with no universally accepted metric, pick a numeric severity scale that you like, i.e. 1 to 4, and specify a location of the findings. The location of your staining is so important as it could indicate various mechanisms behind the surface findings, such as lag ophthalmos, neurotrophic changes, or SLK. Wait to anesthetize the eye when you use your vital dye. If you see significant surface staining, consider corneal sensitivity testing next to rule out neurotrophic changes. This can be performed with a cotton wisp or a dental floss strip. If sensitivity is diminished, you may see why significant findings are not matching your patient's chief complaint. On the other hand, the surface could be pristine. This could be the case if the patient is hypersensitive to pain. Evaluating the meibomian glands should include visualizing structure by transillumination or meibography and determining the function of the glands by expression. It's important to use uniform force to document expressibility. The meibomian gland evaluator is one way to apply uniform pressure to the meibomian glands, and this allows a grading of the expression in 3 areas along the lower lid. Whatever approach you take, remember to be systematic in your exam and have a specific grading scale that you use every time you evaluate the ocular surface. Rule number 3, take a picture. 1,000 words takes way too long. Now that you've performed your exam, how will you convey your findings and treatment goals to your patient? And what if they're largely asymptomatic? Are they going to change their habits just to please you as their eye doctor? With ocular surface disease, anterior segment imaging is critical for patient education and early intervention. Whether your camera is incorporated into your slit lamp or you have a device attached, such as an iPhone with an adapter, this key component to patient education should not be missed. Meibomian gland function has been a growing area of concern in dry eye management. A study out of Duke Eye Center found meibomian gland atrophy in the pediatric population in up to 42% of asymptomatic children. And further studies have connected this atrophy to screen time. This research begs the question, are we doing enough as eye care professionals to intervene earlier and take a proactive approach to help our patients with dry eye in the long run? Meibography can guide early intervention, such as home-based heat therapy, quality omega-3 supplementation, and in-office treatments. Rule number 4, treat and follow. There are very few dry eye diagnoses that do not require follow-up. Selecting a treatment based on your examination and the suspected mechanism of action should always be followed by a set appointment to ensure progress and improvement in clinical findings and symptoms. In-office treatments are a growing part of optometric practice, and these are a first-line therapy for a good reason. Patients with every level of disease, especially the evaporative variety, can benefit from the light-based therapies such as IPL, thermal-based treatments, including Tear Science LipiFlow, Systane iLux, and Tear Care, or biofilm removal such as Blefx. With these treatments, pharmaceutical intervention may be held off initially. Aqueous deficiency symptoms can be improved with treatments that augment tear volume, such as punctal plugs or the new varenicline 0.03 milligram solution nasal spray. And such treatment should come to mind in cases of Sjogren syndrome or ocular graft versus host disease. Most topical treatments target inflammation, which is almost always a major component of underlying evaporative or aqueous deficient mechanisms. Cyclosporine formulas and lifitegrast ophthalmic solution are now tried and tested primary weapons in our arsenal of therapy. If a patient presents acutely with significant surface findings and symptoms, topical steroids that work on the surface are a great option to quell these flares. Although loteprednol-based topical steroids have become commonplace in managing surface inflammation, attention should still be given to the length of use and refills authorized, along with IOP monitoring. Make sure the patient received the drug you prescribed and not a ketone-based generic substitute. For moderate to severe cases, biologic drops such as Regenerize ophthalmic solution, amniotic membranes, and autologous serums such as Vital Tears are also excellent options. Whatever treatment you choose, set a reasonable follow-up visit to assess effectiveness and make a plan to improve the progress you have or haven't made. Rule number 5, provide a written plan. Before you send your patient out the door with a bag full of tears, prescriptions, supplements, and heating masks, you should really write instructions down for them. Sometimes a pre-printed grid or checklist of your typical choices makes things orderly and easy to understand. It doesn't get much simpler than that. As dry eye becomes increasingly common in our patient population, keeping some ground rules in mind at the beginning of your evaluation can lead to better outcomes. Additionally, establishing some sort of systematic approach to patient care will help prevent misdiagnosis, allow for proper treatment earlier, and improve your patient's satisfaction with you and your care.
Dr. Cook's guidelines are sure to give you a leg up on the OSD space. Do you have any additional rules of thumb that you would add to his list? Write us at editors@bmctoday.com and let us know. We'd love to hear from you. To end the episode, we have a great piece on patient education by LA optometrist Hardeep Kataria and her co-author, Vancouver optometrist Mahnia Madan. We have the pleasure of hearing them both read us their article on effective education strategies for non-adherent patients.
Effective management of dry eye disease is largely dependent on patient adherence, much like it is with glaucoma, where patients must follow at-home treatment and attend frequent in-office follow-ups. Patient education and patient adherence are two major challenges that optometrists encounter in our daily management of patients with dry eye disease. Non-adherence often reflects a patient's understanding, or lack thereof, of the severity of their disease and may be driven by symptomatology. Non-adherent patients bring a burden of treatment upon themselves as their disease process worsens, on their healthcare practitioners as we struggle to find treatments that are effective against worsening disease processes, and on the healthcare system as the financial cost to treat them increases. If 60% of patients use artificial tears only when they have symptoms, how do we fill the gap for asymptomatic patients? As healthcare practitioners, we must seek to understand how to overcome barriers to care, such as patients' lack of understanding of their disease, the complexity and cost of treatment, inadequate follow-up, treatment side effects, and poor patient-doctor connections. This article explores key strategies for improving patient education, even for those tough, asymptomatic cases. Imagine this scenario. An established patient calls the clinic with concerns of increasing light sensitivity and fatigue whilst using the computer. The receptionist recommends they try blue light blocking glasses to help alleviate their symptoms. Not surprisingly, the patient tries the glasses for several months but notes no improvement in symptoms. Assuming the recommendation came from the doctor, the patient decides to seek a second opinion from another clinic. In this situation, an innocent recommendation made by an undertrained staff member resulted not only in the loss of the patient to the practice, but also in the undertreatment of dry eye disease. Because our staff are often the first point of contact for our patients, they should be well trained to provide patient education. Kamber Salani, OD, explains that patient education can be in the form of pamphlets, videos, blog posts, and social media. In fact, it is important to share analogies that may resonate with them. For example, you may not feel the cavity, but it's important to treat it so it doesn't lead to something worse. Signs precede symptoms. Or, just as proper dental hygiene can help prevent cavities and gum disease, good eyelid hygiene or good ocular surface health can help with contact lens comfort, whiter eyes, clearer vision, less dyes, better LASIK post-op outcomes, and much more. David Kading, OD, agrees with a focus on patient education as a form of preventative care. As a profession, we must educate people before they have the problem, he says. Have your technicians initiate a discussion with patients about any symptoms they report on questionnaires and surveys, and get them to assist you in interpreting imaging such as meibography. Creating a custom-tailored treatment plan for each patient is imperative and demonstrates to them your investment in their treatment success. Opportunities to educate exist even after the patient leaves your office. Consider sending a personalized follow-up email with recommended educational materials such as best eye makeup tips, or include a direct link to your favorite educational article. We surveyed 35 primary care optometrists who treat dry eye disease and asked the question via social media: what is your most valuable tool in educating asymptomatic dry eye patients? An overwhelming majority reported photo documentation to initially educate patients, to track progress of treatments, and to assist in quantifying improvements that patients can celebrate. Sharing videos of blink dynamics or meibomian gland expression after treatments can also be invaluable. We have found that when patients can visualize a tangible improvement from their investment in a dry eye treatment, it provides them with motivation to continue. For Jacqueline Garlick, OD, meibography is her favorite diagnostic tool for patient education. I can explain meibomian gland atrophy all day long, but when patients see their glands versus what normal glands look like, they better understand my concern. Jacob Lang, OD, uses slit lamp photos to establish patient-doctor trust. Anytime I can document a sometimes complicated and multifaceted disease state and actually show the patient what's broken, think X-ray and a broken bone, it's a win-win. The patient's engagement and understanding jumps forward light years, allowing a baseline to the why with our treatment strategy and setting the stage for further conversations at follow-up appointments. Especially when a treatment pivot occurs, it helps me point out why while building the patient's trust and engaging the patient in the treatment strategies and therapies. Analogies are an easy and relatable method of highlighting and enhancing patient understanding. Mark Blumenstein, OD, likes to use them to demonstrate for patients the consequences of lack of treatment or the benefits of a treatment. For example, when educating about cataracts, I liken the lens to an M&M candy, with the coating being analogous to the capsule and the chocolate center the lens material. In the example of dry eye patients, it is the tear quality that induces a reduction of visual quality, creates fluctuation, and can create an inhospitable environment for all refractive options. Tracy Doll, OD, likes to set expectations using analogies. The dental model is a good example. She explains, if you don't brush and floss, then your dental cleaning exams and dental work are more costly. This is the same. I also discussed that dry eye is a chronic inflammatory condition that will never be cured, but rather needs to be managed consistently. Encourage patients to bring family and friends who can assist in their care to dry eye consultations. If a member of their support system is unable to attend in person, having them call in can also be very helpful.
Dr. Lang expands. There are a multitude of therapies, and not every person or lifestyle allows for every therapy to be successful. I really don't feel this is the patient's fault, but falls really more on the provider, typically whether it was incomplete instructions or resources to remind them of the plan, or simply not passing on the full understanding of the patient and their world. I liken this to the adage about patients being a poor historian, when really it isn't the patient's job to document their history. It's the provider's job. It's our job to understand our patients. An open ear and an interactive conversation are the keys here. One approach involves a direct conversation with the patient who's having trouble keeping up with the therapy, is to address the barriers of the treatment head on. There's no need to shy about it. In one study, Wu and Yin identified barriers to adherence to glaucoma topical therapies such as forgetting, drug side effects, and inconvenience in seeing the doctor. Addressing these barriers directly can be helpful. For example, if the patient is having transportation difficulties, a telemedicine follow-up appointment, might make things a little bit easier. Now, Dr. Galrich directs patients on how to form habits. She says, some example questions you might consider asking your patients include, how can I help you achieve this? Are there any barriers you perceive that don't allow you to do this? An example of an instruction might be to use lid hygiene sprays in the shower if that helps the patient remember better. Dr. Salani then takes this information and provides guidance through various aspects of their daily habits, including diet, cosmetics, contact lens wear, digital device use, etc. This way, we're not only their eye doctor, but their trusted partner in the journey to optimal eye health. Treatment of a chronic disease such as dry eye is costly. In fact, Dr. Dahl recommends addressing the cost burden of non-adherent patient directly with them. The more non-adherent with home therapy or lid hygiene or nutraceuticals or any topical drops that their patients are at home, she tells them she will need to do more in-office treatments. She explains out-of-pocket treatments can be spaced out longer if the patient will do their home therapy. There are several indirect costs of dry eye disease that patients may not be aware of too. Now, these indirect costs include time away from work for these multiple appointments, loss of wages due to missed work, and reduced productivity due to dry eye symptoms at work. Often these indirect costs end up costing the patient more than even the direct costs. Now, Greco et al. Reported that worsening of the ocular surface disease index scores were in fact directly associated with increased impairment in work and non-work related activities. Research also supports that the use of cyclosporin reduced the cost burden of dry eye disease due to reduced frequency of follow-up visits and reduced dependency on having to buy over-the-counter eye drops. There's also less potential for additional interventional therapies such as punctal plugs. Asymptomatic patients of a chronic disease process such as dry eye disease can create a significant burden for themselves and for their healthcare provider. By implementing these patient education strategies, we hope to move the needle in the widespread understanding of dry eye disease and its visual consequences.
Maybe you already knew this, or maybe you needed to be reminded that sometimes the issue isn't convincing the patient to follow their dry eye treatment, it's getting them to continue it for the long term. Or maybe you just learned something completely new. Until the next episode, follow us on all things social, come find us at Vision Expo, but above all, be well. Thanks for listening.